Yes.
Yes.
Okay. Perfect. Wait, where did it start it back? What question were we at?
36.
36. Okay.
An 18-year-old woman, an 18-year-old woman is brought to the physician because of irregular menses over past 3 months. Mens occur at 14 to 40 days of intervals. Menstrual flow varies from spotting to heavy cramping and bleeding. The later symptoms have the later symptoms have caused to miss her school. Her last menstrual period was 3 weeks ago. Menarche was at Menarche was at age 12 year. Menarche was at age of 12 years. Mens has occurred at regular 28 days of interval for 6 years. She has a sedentary lifestyle. She is 165 centimeter, 5 feet 5 inch tall, weight 63 kg, BMI 23 kg per meter square. Pelvic examination shows no abnormality. Urine pregnancy test is negative. Which of the following is most appropriate next step?
What is it? Ready?
Yes.
Cyclic progesterone therapy. Cyclic progesterone therapy is a key treatment in management of anovulation. Common causes of anovulation include pregnancy, PCOS, normalities or immaturity of the hypothalamic pituitary ovarian axis, menopause or premature ovarian failure, inadequate nutrition, chromosomal abnormalities, thyroid disorders, and ovulation presents with irregular intervals of menstruation associated with heavy vaginal bleeding and menses occur because of continued endometrial development. Progesterone therapy acts to inhibit FSH and LH, preventing ovulation. Progesterone therapy also maintains the endometrial lining and causes its transition to a secretory rather than proliferative endometrium. When progesterone is withdrawn, bleeding occurs if the anovulation is caused by abnormality or irregularity of the HPO axis, as is often the case in young women. Bleeding will not occur if the anovulation is caused by structural abnormality of the uterus or estrogen deficiency. Hmm. Conjugated estrogen therapy is typically used to treat the vasomotor symptoms of menopause. Conjugated estrogen therapy is associated with an increased risk of breast cancer, hypercoagulability, cardiovascular mortality. It's also associated with endometrial cancer when used without progestin. Would not be effective in treatment of patients and ovulation. Hysteroscopy will be useful to evaluate the uterus for structural causes of irregular menses. However, these patients' symptoms are more consistent with an ovulation than with polyps or fibroids, and hysteroscopy will not be the most useful next diagnostic step. I don't understand why progesterone, sorry.
Why?
Yeah,
Why
I don't,
progesterone is given?
yeah, the
Like,
explanation.
just simple explanation. I know that progesterone actually giving progesterone actually maintains the menstrual cycle. Like menstrual cycle usually 28 days, but if there is irregular menstruation, so that's why progesterone is given to maintain the regularity of the menstruation. That's what I remember. I don't know actual. mechanism of action you are looking for.
Okay.
You can you can search this question over Gemini and let's see what they told. You can
Oh,
copy and paste.
this thing is not gonna work. I'm pretty sure.
Yes,
Let's
it
see.
will gonna work.
I never know how to copy it. Let me copy from here. Now it doesn't give me the option right here. Copy.
Why is that?
I don't know.
Okay, I
Okay,
am
paste.
sending you the copy option in
No,
the
I got it. It
okay,
works.
okay, it works.
Okay. What is the correct answer? The patient presents with regular menses of 3 months, occurring at 14 to 12, okay, with
Go
heavy
below.
cramping.
They actually read the whole
What is it? Which one?
yes, let's
Oh,
analyze.
right here. Okay.
Yes.
No, this says the other option, but what is the right option? It says final answer is A, but it's not A.
Okay,
It's B.
they actually interpret wrong then. Sometimes it happens. I have already told you. Okay.
Okay. Okay. Because here they say that you have to give them combined OCPs. Okay.
But in here the final answer is B. I have okay. I am sharing my screen. Now you can
Okay.
see.
What is it?
Wait. Okay. You can see now. You can see now.
No. No.
Now.
Now. Yeah. Mm-hmm.
Okay. So the final answer is B. So in here,
Good.
okay. So cyclical progestin therapy is common. So in anovulatory cycle, the endometrium proliferates under unopposed estrogen, leading to irregular shedding. Progesterone helps to mature and stabilize the endometrial lining, leading to predictable withdrawal bleed when progesterone is stopped. These helps to regulate cycles and prevent endometrial hyperplasia. So main word is it helps to regulate cycle and like it progesterone helps to mature and stabilize the endometrial lining.
Okay.
So it addresses the underlying anovulation by providing progesterone and component of the cycle. And the other options are not important now. Okay.
Yeah. Okay. Thank you. Thank you. Share my
I don't
screen.
know why your whole screen is captured. Like I
What
can
do you
copy
mean?
I can copy the question apart from the answer. Then I actually
You just copy the question, not the answer choices? Is that what
yes.
you Oh,
Even I
maybe.
can copy anything. Like okay, let's leave it. Okay.
Okay.
Maybe
Okay.
there is a
Never
problem with
mind.
the reader. Like
Yeah.
yes.
Hmm. Okay, next.
A 37-year-old woman, gravida 1, para 1, comes to the physician with a follow-up examination. 6 weeks ago, 6 weeks ago, a pap smear showed low-grade intraepithelial neoplasia. She has no symptoms and takes no medications. She is sexually active. She is sexually active with one partner, uses a diaphragm for contraception. Examination shows a normal vagina, cervix, and uterus. Colposcopic examination show an acetowhite area with punctuation. Acetowhite area with punctuation. The entire squamocolumnar junction cannot be visualized. A biopsy specimen of the cervix shows CIN3. A biopsy specimen of the cervix shows CIN3. Which of the following is most appropriate next step in the management? Uh,
Ready?
yes.
Is decon biopsy of the cervix. CIN3 is a high-grade cervical lesion with an increased risk of progression to cancer. Cervical cancer is classically associated with HPV, high-risk strains 16, 18, 31, 33. High risk factors include multiple sexual partners, smoking, immunosuppression. Screening pap smear are recommended every 3 years in women 21 to 29, and every 5 years with HPV co-testing um, in women 30 to 65. Abdominal pap smear cytology results are most commonly evaluated with colposcopy, which allows for the visual assessment and biopsy of abdominal lesions. Colposcopy is deemed inadequate if the entirety of the squamous columnar junction or transformation zone is not visible, as there is a possibility of undiagnosed cancer. In this case, the biopsy confirms CIN3, which requires excision via cone biopsy of the cervix, also known as skull neck conization. The cone biopsy serves for further evaluate a larger region of the cervix for cervical carcinoma. It may be curative if a margin of normal cervical tissue is identified on histology. Lip could be an alternative, and it's not E or F. Cryotherapy of the cervix would be appropriate therapy for CIN1, CIN2 and 3, or for persistent CIN1. However, it is not appropriate therapy for CIN3 when the entire transformation zone was not visualized because the risk of unrecognized cervical carcinoma. Cryotherapy. Vaginal hysterectomy is a potential treatment option for recurrent CIN2 and 3 as well as cancer. However, it's important initially to fully evaluate the entirety of the cervical transformation shown via cone biopsy. Okay.
Okay.
Okay. Next.
A 12-and-a-half-year-old girl is brought to the physician. She had not had menstrual period for 5 months. Menarche was started at age 11 years. Mm, Mens has occurred regular 30 to 90 days of interval lasts 1 to 5 days. Last 1 to 5 days. She plays softball in the spring, participates in the physical education class at school 2 times weekly. She is not sexually active. She is at 60th percentile of height, 40 percentile of weight. Examination show no abnormality. Which of the following is most likely diagnosed? I mean between these two, athletic amenorrhea and normal development.
Me too. Ah, that's right.
Sometimes, uh, like in the beginning of the menses, it
Yes,
happens.
yes. I'm
But she
thinking
is not. She plays softball, isn't it?
in the
Very
spring, in the spring only.
yes, not
2 times weekly. Yeah.
not like severe. Okay, okay. Let's see.
So it's normal development. Normal development of the HPO axis takes time. It is not uncommon for adolescent girls to have irregular periods for the first 1 or 2 years after beginning menstruation. This is due to immaturity of the HPO axis that results in irregular and non-cyclic gonadotropin release hormone, so GRH release from the hypothalamus. This causes varying FSH and LH concentration, leading to anovulation amenorrhea. This also affects the concentration of estrogen and progesterone in the body, resulting in varying degrees of secondary sexual characteristics progression. It is not B, athletic amenorrhea is due to suppression of the HPA axis with increased energy demands, leading to decreased production of GRH. It occurs most commonly in thin females that are undergoing rigorous exercise or training regimens, and will not be expected with this patient average amount of exercise.
A 27-year-old primary gravid woman at 38 weeks of gestation is admitted to the hospital in labor. She has had spontaneous rupture of the membrane 2 days ago. On arrival, her temperature is 102, cervix is 100%, effaced 4 centimeter dilated. The vertex is at 1 plus station. Abdominal examination show exquisite tenderness of the uterine fundus. Pelvic examination shows a mucopurulent cervical discharge. The fetal heart rate is 180 per minute with good variability. 180 per minute with good variability. Treatment of IV ampicillin and gentamicin is begun 2 hours after admission. 2 hours after admission, the cervix remains 4 centimeter dilated. She underwent cesarean delivery. She underwent cesarean delivery for the arrest of active phase and delivers in healthy newborn. 6 hours after the delivery, the patient's temperature is 102. The patient's temperature is 102. Which of the following is the most likely cause of this patient's fever?
Mm,
Okay.
okay. Polymicrobial infection. Endomyometritis is an acute polymicrobial infection of the uterine endometrium and myometrium with normal vaginal flora. Patients typically present with fever and severe tenderness of the uterine fundus. Risk factors for the development of endomyometritis include premature or prolonged rupture of membranes greater than 18 hours, spontaneous or elective abortion, the C-section and placement of a IUD. Physical examination findings include uterine tenderness on bimanual exam and mucopurulent discharge, along with fetal tachycardia and tochometry, uh, a stress response to the maternal infection and fever. Okay. Broad-spectrum antibiotics such as ampicillin and gentamicin are typically used to allow for appropriate coverage of the polymicrobial infection, which typically involves an array of gram-negative and anaerobic bacteria. Hmm. It's not aseptic thrombophlebitis is a rare sequela of endometritis that can lead to local invasion and infection of pelvic vein walls, which causes intimal damage and thrombosis. This condition typically presents with pelvic pain and a fever that can be widely variable in range. Diagnosis typically occurs through blood culture. If this patient were persistently febrile despite appropriate antibiotic treatment for endometritis, septic, whatever should be considered. I don't understand. It says that the polymicrobial infection is covered with antibiotics like gentamicin and ampicillin. And it says that on the question they gave them gentamicin and ampicillin, but
Yes.
she still has the 6 hours later she still has the infection. She still has fever. So shouldn't the gentamicin and ampicillin have covered the
No.
polymicrobial?
Should be, but it like In the vaginal flora, normal vaginal flora, there is multiple things. Like candida is one of the vaginal flora. So you cannot kill candida with the help of this ampicillin and gentamicin. And candida can cause infection. If you give broad spectrum antibiotic, then in the pregnancy, mainly in the pregnancy, the normal vaginal flora actually gets upper hand and causing another sort of infection. So we need broader coverage that will cover gram positive, gram negative, arrow, anaerobe, everything, along with sometimes antifungal also. You got my
Okay.
point.
Okay, so it says broad spectrum such as ampicillin and gentamicin are typically used
For
to
polymer,
allow for polymicrobial infection. So so basically this is not, you need more than this.
yes. There are
Okay.
other drugs too, like meropenem, vancomycin. They are broader spectrum than the ampicillin and gentamicin.
Okay.
You, yes.
Okay. Next.
27-year-old woman comes to the physician because of painful vulvar swelling. For 2 days, painful vulvar swelling. She had 3 episodes of Neisseria gonorrhea infection treated successfully with oral antibiotic. For past year, she has 4 centimeter tender fluctuant mass at the labia majus. 4 centimeter tender fluctuant mass. Which of the following is the most likely? Labia majus. What is your differential?
Mm, mm,
Like is Bartholin gland abscess can happen, but no fever is present. But
mm,
the location looks like the Bartholin gland, isn't it? Labia
mm,
image.
yeah, probably.
Are you
Info.
thinking anything else?
Vulvar, no, either that or vulvar vestibular, but I don't, vestibular of the,
Vulvar
yeah,
vestibulitis.
no, it's not at that, it's not at that location. So yeah, that'll be the only one that makes sense. Ready?
Yes.
Bartholin duct abscess. Bartholin duct abscess can occur when Bartholin gland becomes obstructed and infected. Bartholin glands are located on each side of the introitus and provide secretions that lubricate the vagina. Occasionally, the ducts of these glands becomes obstructed, leading to Bartholin cyst. This presents as a small area of painful fructal and swelling over the posterior aspect of the labium majus. With ongoing obstruction and inflammation, infection can develop, leading to Bartholin gland abscess. Markedly redness and tenderness to palpation of the cyst. Abscesses are commonly polymicrobial, but Neisseria gonorrhea is a frequent isolated aerobe. They are treated with incision and drainage, often with placement of catheter to promote complete evacuation. It's not vulvar vestibulite. Vulvar vestibular presents with redness and hypersensitivity of the vestibule or opening of the vagina, leading to dyspareunia, particularly with penetration. It will not be expected to cause a vulvar abscess. Let me Google Bartholin Grand cyst location. So around here.
Yes.
So that's the labium major. That's the, I'm guessing it's the minus labium minus. So it's kind of inside the minus, the labium
Th
minus.
that was the labia majus area, isn't it?
Or is it? So is it around the labium? Wait, that's the minus, the major, the big one here, and then the
Where?
little. Oh no.
No,
This
no.
big
Just see the labia majora and labia minora. Then you can differentiate. The area is little. The inside is labia majus and the big one is inside one is minora and the bigger one is labia majora.
because they said this is the labia minora.
The outside one and the inside is
The
labia majora.
no, the inside cannot be the majora. The majora must be the outside one.
N-
Oh, there you go. This one. You see, the minora is this thing, and the majora is just the skin right here.
So
So they
how?
said that.
Okay.
So they said the Bartholin says, you see, it's like inside the this one. So that's why I was confused when they say on the question that
It is on the labia majus.
yeah, it says fluctuate mass on the labium majors. Yeah, so that's why I was a bit confused. But okay,
Okay.
I'm guessing they're trying to say that it's inside
Near the. Okay.
near it. And then what was the other one? Sorry, the other one was vulvar
I-
vestibulitis. Vulvar vestibulitis location. I do not know, but mm, but it's also vestibulodonia, vulvar vestibule, which is the area around the vaginal opening. Okay. Uh, okay, I don't know. I'm guessing it's around this area. I don't know. Okay. Either way, there will be basically pain on penetration. That's what they're trying to say. Anyway.
Okay.
Okay.
Valvode. You are talking about vestibulodynia.
But yeah, the vulva, the other option choice, vulvar vestibulitis. Yeah.
Okay.
Hmm. Yeah, I just saying around where the vagina opens. Okay, next.
47-year-old woman comes to the emergency department because of 4-day history of increasing pain with urination. Increasing pain with urination 5 days ago, she began treatment with the sulfonamide antibiotics. Sulfonamide antibiotic by her primary care physician after a phone consultation. She has not a relief of her symptoms. She has no history of serious illness. She has no history of serious illness, abnormal pap test, or sexually transmitted disease. She currently takes no medication. She states that she has had increasing stress during the past month. Pelvic examination show explicitly tender ulcer on the labia minus. A photograph of the lower labia is seen. Which of the following is most likely diagnosis? Painful tender ulcer. They haven't talked about any node, isn't it?
Mm-mm.
Okay.
Condyloma acuminata, HPV, molluscum contagious. What was molluscum contagiosus? Oh,
Umbilicated patches, umbilication. Pox
yeah,
out of the box.
yes. Okay. Mm,
You know the sketchy very well. That's why it is very easy to talk to you.
to talk to me. HSV1 genital infection is
Because
characterized.
I talk in such a way, people will not gonna understand. Okay.
No, people that have seen sketchy will understand when you.
Yes.
Yeah.
Lots of the people is not a fan of sketch. I don't.
What?
Yes,
That's
truly,
crazy.
truly,
Like,
people don't like it is time consuming. Like you need to see, you need to absorb. That's
But
why
when you see it like once or twice, you it just stays in your mind. It's just I don't know. I don't
yeah.
know how you can go through whole medical school and microbiology without seeing sketchy. Like how do you
I,
pass micro?
I have passed micro by reading the Lynch book. I found sketchy
No,
in the later
oh
one.
my
I
God.
I found sketchy after I passed my microbiology. Truly, I haven't seen the sketchy before.
Wow. But you saw it for step one.
Yes,
Okay, yeah. Okay.
like
HS.
Pathoma, I have found Pathoma later on. Pathoma is a
Oh,
wonderful
you
book.
know, I never used it was. I never used Patom. Everybody was like, use
Yes,
Patoma, use Patoma. I never used it, but
you
is
use
it good?
Guljan. Yes, it's a wonderful book.
Yes,
Just
everybody was there like
just you
Patoma.
the all the information, like you can memorize whole book, you can feel like that. That's the way the person Hossein Sattar actually explained. You
Hmm.
need the explanation also. Only reading the book you will not gonna understand,
Hmm.
because a book, that book is written in a very easy manner.
Hmm.
Okay.
Okay. HSV-1 genital infection is characterized by painful vesicles in the genital area, vulva, vagina, cervix, perineum, and may be associated with pain during urination. Most cases of genital herpes are caused by HSV two. However, HSV1 has also been associated with genital herpes infection. Typically begins with formation of vesicle, which lies and progresses to shallow, painful ulcers with red border. This painful rash can be exacerbated during urination, in which acidic urine passes over the open vesicles and ulcers. This dysuria may be misinterpreted for underlying UTI, which may be treated with sulfonamide antibiotics. However, this will not be effective in treating HSV. HSV is treated with cyclovir, valacyclovir, which are, that this reduces the duration and viral shedding and symptoms. And it's not, I was confused with those two. Condylomata accuminatum genital warts associated with HPV can appear on the penis, vagina, vulva, anal canal. Patients with HIV are prone to severe condylomata lesions in these regions. Condylomata comminuta presents with soft, fleshy growths, and the diagnosis is made by exam. Molluscum contagiosum caused by pox virus, characterized by small painless papule with central lubrication and may appear anywhere on the body. It's treated with cryotherapy and topical T-chloroacetic acid and benzoyl peroxide. Okay, next.
A 37-year old woman, gravida 7, para 4, aborted 2, 40 weeks of gestation, is admitted to the hospital in labor. Spontaneous rupture of the membrane along with severe abdominal pain. Occurs 4 hours ago. The pain is constant and sharp, unlike the labor pains of her previous pregnancy. Her pregnancy had been uncomplicated. Her last Her last pregnancy ended in caesarean delivery at term. For breech presentation, her temperature is 98, pulse 80 per minute, respiration 17 per minute, blood pressure 122 by 68. The fundal height is 28. Leopold maneuver shows small show fetal small purse above the fundus. Leopold maneuver shows fetal small purse above the fundus. External monitoring shows fetal tachycardia. External monitoring shows fetal tachycardia with late deceleration and loss of beat-to-beat variability. Which of the following is most likely diagnosis? Oh, signal.
Ready?
Yes.
Uterine rupture is a dangerous complication of pregnancy where the muscular wall of the uterus tears. Severe pain is a common initial finding. Hemodynamic stability can manifest in the mother with tachycardia, hypotension, and in the fetus with late deceleration, tachycardia, bradycardia, and loss of beat to beat variability. If uterine rupture occurs during labor, sudden loss of fetal position is a high suggestive finding. Fetal parts may be palpable above the fundus with Leopold maneuvers. Risk factors for uterine rupture include vaginal birth after C-section, okay, multiparity and induction of labor with prostaglandin analogs or oxytocin. Uterine rupture is treated with emergency laparotomy. Okay, next.
Oh, white is not option A,
So,
abruption.
abruption placenta.
There is abdominal pain. No bleeding is present, I know.
Abruption placenta is a premature separation of placenta from endometrium. Presenting findings include abdominal or pelvic pain, abnormal vaginal discharge, and tetanic contractions. An abnormal fetal heart rate may be detected, and fetal demise may occur if the abruption is large. Uterine wall remains intact during placental abruption, and fetal parts will not be palpable above the fundus.
So what's the clue you have found in this question to diagnose uterine
It's
rupture?
the small parts above the fundus.
Show small parts above the fundus. Okay,
Next.
okay. A 22-year-old primary gravid woman at 24 weeks of gestation has had fullness in the lower pelvic area for 12 hours. She has no contraction. Fundal height is 20 centimeter. Her fetal heart tone are good. Examination shows the fetus is breech presentation in the vagina. No cervix is palpated. Which of the following is most likely diagnosis?
Ready?
Wait. Okay.
So it's incompetent service. The American College of OBGYN defines cervical incompetence or cervical insufficiency as the inability of the cervix to contain the pregnancy, fetus, placenta, and neonatal sac without the presence of contraction, labor, or both, typically during the second or early third trimester. Inability of the cervix to contain the pregnancy without contractions, labor, or both in the second and third trimester. The condition is associated with spontaneous abortion, preterm or premature rupture of membranes, and preterm birth. Classically, when symptomatic, it presents with feelings of fullness in the lower pelvis in the absence of contraction or labor. Speculum exam may show a dilated or effaced cervix or protrusion of the pregnancy through the cervical os into the vagina, as in this example. Mild cases without dilation of the external os may go undetected. Cervical length measurement may reveal a short cervix with a cervical length less than 15 to 25 millimeters. Treatment is indicated if the degree of cervical insufficiency is significant enough to threaten the pregnancy. This is accomplished through cervical cerclage, which is the placement of a suture into the cervical os to narrow the canal and maintain the closed cervix. The suture is then removed at the time of labor or around like 36 to 38 weeks. And then it's not D. Placenta previa classically presents with painless vaginal bleeding during the third trimester and is defined by placenta that partially or completely covers the internal cervical os, often visualized on screening ultrasound. Unless placenta migrates away from the os, the C-section is generally required to prevent significant bleeding, as well as fetal or maternal death. Okay, next.
A 37-year-old woman, gravida 5, para 3, abort 140 weeks of gestation, is admitted for labor. Contraction began 2 hours ago. She has not had vaginal bleeding. She has not had vaginal bleeding or loss of fluid. Her pregnancy has been uncomplicated. Her last child was delivered vaginally. Her last child was delivered vaginally at term. Weight is 4,300 gram. At her last prenatal visit 1 week ago, the cervix was 50% effaced, 1 centimeter dilate. The vertex is -2 station. Examination shows no contraction that occur every 5 minutes. Cervix is 50% effect, 6 centimeter dilated. Cervix is 50% effaced, 6 centimeter dilated. No presentation or part can be felt. A fetal heart tracing shows no abnormalities. Which of the following is the most appropriate next to the management?
Ready?
Yes.
Or is ultrasound of the pelvis. Ultrasound of the pelvis will allow the clinician to determine the fetus position when not presenting fetal part can be felt at the cervical opening. Fetal malpresentation occurs when any portion of the fetus besides the occiput presents at the cervical os. This malpresentation prevents the head from properly engaging in the pelvis for descent. In some cases, excess amniotic fluid from polyhydramnios can prevent any fetal part from presenting at the cervical os until the rupture of membranes occurs. Serious complication that can occur in fetal malpresentation is umbilical cord prolapse. Because of the lack of LCT of head engagement at the cervical os, the cord can protrude through the cervix following the rupture of membranes before the fetus descends into the pelvis. Um, Further contractions can cause cord compression, and the cord can be impinged by the fetus, resulting in fetal hypoxia. Oh, okay. Given the high risk associated with vaginal deliveries in case of fetal malpresentation, C-section may be necessary. Cord prolapse, however, is an obstetric emergency requiring immediate C-section. And it's not E. C-section is generally indicated in fetal malpresentation. However, the best next step in management is to determine the fetal position with ultrasound, rather than move directly to C-section prior to confirmation of the fetal lie, as vaginal delivery may still be an option. Okay, next.
A 27-year-old newly gravid woman comes to the physician because she has been unable to conceive for 3 years. She has been unable to conceive for 3 years. Mens occur at 35 irregular 35 to 40 weeks of interval and last for 8 days. Laparoscopy 8 weeks ago show spill from both fallopian tube after methylene blue dye installed into the cervix. There is no evidence of endometriosis. Her husband has 2 children from previous marriage. Physical examination shows normal uterus, no palpable mass. Postcoital show motile sperm. Which of the following is most likely diagnosis? cervix is patent. Irregular menstruation.
What was danazole again?
Gonadotropin agonist.
Like G, like
Sorry.
GRH
Yes, GnRH agonist.
agonist. Mm, 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 mm. I always forget the leuprolide and clomifene
Loc,
mechanism of
loc, Loprolide
I always forget
and
those.
goserelin is anti-estrogen, as far as I remember,
Leuprolide is anti-estrogen.
isn't it?
I don't. I always forget those two. They're always the two that I don't know. I forget them.
Loprolide and goserelin. Loprolide, like
And,
these
and,
things are finasteride,
and clomiphene.
clomiphene, tamoxifen, raloxifene, clomiphene. These are selective estrogen receptor modulators.
Mm, I don't know. I always forget those ones. I don't know. Okay, ready? I don't think it's done answer. It's never the answer on the things. Study clomiphene.
Think others like G.
Ready?
Okay,
Ready?
we are wrong.
No, I got it. It's clomiphene, but I don't know how I got it. Clomiphene stimulates ovulation. Is usually the answer, but I always forget the mechanism of action. Clomiphene stimulates ovulation by acting as an estrogen receptor antagonist to block the negative feedback on GnRH in the hypothalamus. Wait. Ah, okay. Clomiphene thereby increases the downstream effects of GnRH. It is commonly used in women struggling with infertility due to anovulatory cycles. An ovulation presents with irregular intervals of menstruation associated with heavy vaginal bleeding when menses occur due to continued endometrial development. The ovulation is caused by pregnancy, PCOS abnormalities in the HPO axis, menopause, all of that. Other causes of infertility in women include fallopian tube blockage, structural abnormalities of the uterus, thyroid disorder. Okay, so it blocks estrogen. So it looks like there is no estrogen and the hypothalamus releases more GnRH. Okay. Danazole acts as a synthetic androgen and partial androgen receptor agonist to prevent ovary from secreting estradiol. It is used in endometriosis, but has no role in infertility. So androgen agonist. No, androgen, not estrogen. Wait, yeah, well, same thing. Leuprolide is structurally similar to GnRH. Oh, so this is the structurally similar to it. Okay. When used in pulsatile manner, it stimulates the downstream effect of GnRH leading to ovulation. However, when used continuously, it acts as a GnRH antagonist to down-regulate FSH and LH. Unlike clomiphene, which is oral, leuprolide is injectable, making it less ideal for initial pharmacotherapy. Okay, so clomiphene, estrogen antagonist. Danazole is estrogen agonist. And leuprolide is GnRH
GnRH
agonist.
both it can work as agonist and antagonist.
Antagonist, leuprolide. I know I'm gonna forget it again, but okay. Okay, next. I wish
Eh,
they had like a mnemonic for that or something.
which okay, I don't know
For
actually.
you have a name for leuprolide and clomiphene and
No, no,
clomiphene. No.
no. I have to see. Then I can make.
Mm.
Okay. A 21-year-old primary gravid woman at 10 weeks of gestation She had severe nausea and she had unable to keep anything in her stomach for 48 hours. She has mild nausea and vomiting for 6 weeks. Examination shows normal finding. Ultrasonography shows a normal 10 weeks of gestation. Ultrasonography shows a normal 10 weeks of gestation. Which of the following is the most appropriate next step?
Don't know.
What is your
Ready?
diagnosis?
I'm thinking hyperemesis adudarenhua.
Hyperemesis gravidarum serum urine. I think that ketone is positive.
You
Okay,
think? Okay.
urinary ketone. As far
Oh,
I remember. Okay, let's see.
you are right. Severe inability, severe nausea with inability to maintain oral intake is a common presenting symptom of hyperemesis gallonado and can lead to clinically significant dehydration and starvation ketosis, which can be assessed through measurement of urinary ketones. Um, Hyperemesis is usually associated with weight loss in early pregnancy and extend past the first trimester. When typical morning sickness resolve, tachycardia, mild hypotension, and signs of dehydration, Rhymochus member will be expected on vital signs and physical exam. Results of lab studies show ketones in the blood and urine, and depending on the degree of severity, electrolyte volume, and acid beta abnormalities, hyperosmolar hyponatremia, hypokalemia, hypochloremia, metabolic acidosis, metabolic alkalosis, metabolic acidosis, caused by vomiting, dehydration, ketogenesis, and severe volume contraction. So everything is low. Hyponatremia, hypokalemia, hypochloremia. As HG is commonly associated with molar pregnancy, it's also important to check for beta HCG concentration and obtain a pelvic ultrasound. Treatment of HG includes vitamin B6 supplementation, IV fluids, antiemetic, and severe cases TPN. Okay, perfect. Next.
An otherwise healthy 27-year-old woman comes to the physician 2 weeks after noticing a tender mass. 2 weeks after noticing a tender mass in her left breast during breast self-examination. She has a history of similar smaller masses that resolve spontaneously within a week. She feels well and takes no medication. Mens occur at regular 28 days of interval. Her last menstrual period was 3.5 weeks ago. Vital signs are within normal limit. There is no lymphadenopathy. The breasts are symmetric. There is no skin changes. Examination of the left breast show several 1 centimeter smooth, soft, mobile masses and a 3 centimeter mobile, soft, tender mass in the right upper quadrant. Examination of the right breast show tenderness to deep palpation and small masses similar to left breast. Which of the following is the most likely diagnosis? Tender.
Ready?
Yes.
And it is fibrocystic changes of the breast. Fibrocystic changes of the breast occur most commonly in premenopausal women over the age of 35, but can occur also in young patients of reproductive age, such as in this case. Patient may present with various sites of breast pain and lumps unilaterally or bilaterally. Um, The condition is characterized by presence of cysts, stromal fibrosis, and apocrine metaplasia on histology, and it is believed to occur in response to hormonal fluctuation during menstrual cycle. On exam, the cysts may appear blue. Fibrocystic changes is a benign disease and does not generally convey an increased risk of cancer, with the exception of certain subtypes. However, it can result in recurrent mastalgia. If there is associated discomfort, aspiration can be done, which may relieve the symptoms. Cyst aspiration can yield fluid that is clear, milky, yellow, green, or brown, which are likely benign. Supportive care using NSAIDs and well-fitted bra is also appropriate. OCPs has not generally been shown to relieve the symptoms of fibrocystic disease change or cyclic breast pain. Okay, next.
Okay, next. 37-year-old primary gravid woman, 31 weeks of gestation, comes to the physician for a routine prenatal visit. She reports that 4-day history of mildly difficulty breathing. 4-day history of mildly difficulty breathing, especially when in the reclining positioning. She has no history of serious illness. Her only medication is prenatal vitamin. Her temperature is normal, pulse 90, respiration 18, blood pressure 130/80, bundle height 37 centimeter. Pelvic examination shows no cervical or dilatation or effacement. Ultrasonograph shows a normal appearing fetus. Amniotic fluid is 35 centimeter. 35 centimeter. Which of the following is the most appropriate?
Ready?
Sorry.
Ready? Sorry.
Yes.
So, where is it? Antenatal testing. Polyhydramnios refers to excessive level of amniotic fluid volume, increased uterine size relative to gestational age, and is associated with an increased risk of fetal anomalies. Placental abruption, preterm labor, postpartum uterine atony should be suspected when the uterine size and fundal height is larger than expected for gestational age. Polyhydramnios can be diagnosed on ultrasound examination by measuring the amniotic fluid index and AFI. An AFI greater than 20 indicates an excessive amount of amniotic fluid. Polyhydramnios can be idiopathic or associated with a variety of disorders, including maternal diabetes, fetal infection with parvo B19, twin transfusion, and fetal chromosomal or structural abnormalities. Esophageal, um, like esophageal or duodenal atresia and encephaly. Fetal anomalies are the most common cause of polyhydramnios. Antenatal testing, such as fetal ultrasound with biophysical profile, should be done to evaluate for underlying fetal anomalies, along with an amniocentesis to evaluate for chromosomal or genetic abnormalities if ultrasound is non-diagnostic. It's not Weekly amniocentesis for removal of fluid is performed for patients with severe polyhydramnios causing severe shortness of breath or abdominal discomfort. Weekly amniocentesis will not be appropriate in this patient with mild difficulty breathing. Hmm,
Okay.
okay, okay. Next.
A 77-year-old woman comes. 77-year-old woman gravida 2 para 2 comes to the physician. 1 month history of intermittent episodes of vaginal bleeding. Intermittent episodes of vaginal bleeding. Each episode lasts 3 to 4 days, associated with trauma or sexual intercourse. Menopause occurs 26 years ago. She has never had hormone therapy. Her last gynecological examination 38 years ago, following birth of her youngest child. No medication, smoke, Two packs of cigarette for 50 years. Pelvic examination showed 2 centimeter exophytic lesion of the cervix. There is no enlargement of the uterus or evidence of blood or in the vagina. Results of a biopsy specimen of the lesion are most likely show which of the following.
Mm, don't know.
Okay.
Squamous cell carcinoma is an exophytic lesion on the cervix is concerning for cervical cancer, which in about 70% of cases is squamous cell carcinoma derived from epithelial lining of the ectocervix. Cervical squamous cell carcinoma begins from the transformation zone or squamocolumnar junction, which demarcates the ectocervix and its squamous epithelium from the endocervix and its columnar epithelium. This region is the most likely initial site of cervical cancer development and is the target region for pap smear. A screening test for CIN. Risk factors for cervical cancer include infection with HPV, early age of onset of sexual activity, tobacco use, OCP, immunosuppression, infection with HIV or other STIs. Cervical cancer classically presents with vaginal bleeding, occurring with or without intercourse. It may locally invade the bladder and rectum if advanced and can result in hydronephrosis by obstructing the distal ureteral insertion in the bladder. If distant spread occurs, the lung is the common site of metastasis. Wait, I want to read the other ones. It's not adenocarcinoma, it's less common type of cervical cancer compared to squamous. It makes up to 25% of the cervical cancer. Most cases, cervical adenocarcinoma and cervical squamous have the same treatment. Carcinosarcoma or malignant mixed Mullerian tumor is a rare neoplasm which contains components from both an epithelial and connective tissue origin. It's found in the uterus, ovaries, and fallopian tubes. Carcinosarcoma. Clear cell cancer is a histological variant of adenocarcinoma with a poorer response to chemo. Clear cell changes may also be seen in renal and endometrial cancers. What's the relation with the clear cell and there was something?
Clear diethyl we were thinking about this.
Yeah, and it's clear and it's
Clear
cancer of
cell
what?
cancer carcinoma is associated with DS, diethylstilbestrol.
But it's cancer of what? What part?
Cancer of the like ovary.
Ovary. Okay. Papillary serous
Mm,
carcinoma is a rare uterine malignancy, serous carcinoma. Compared to endometrial cancer, it has a higher propensity for lymphatic spread. Okay. Next.
diethylstilbestrol may increase the risk of uterine, ovarian, and breast cancer. These three.
No, but the
Main,
clear you
mainly the ovarian, like this one. If this patient is on diethylstilbestrol, then carcinoma of the ovary, like clear cell adenocarcinoma of the ovary, can be considered.
clear cell adenocarcinoma of the ovary. Okay. Okay.
Okay,
Okay. Mhm.
50. A 27-year-old woman, gravida 2 para 130 weeks of gestation, comes to the physician because of chronic fatigue for 2 months. She has 4.5 kg of weight loss during this period. She has no prenatal care. She has a history of alcoholism and drug abuse. She is 5 feet 6 inch tall, weighs 59 kg, BMI 21. She appears chronically ill. She examination shows pallor. Uterine fundal height is 28 centimeter. Fetal heart rate is 140. Hemoglobin is 6. MCH is 30. Hemoglobin 6. MCH is 30. And MCV is 101. Leukocyte count 4,300. Reticulocyte count 0.1%. Leukocyte, sorry, platelet is low. PT is uh, almost normal. And bilirubin 1, ALT is 16. Which of the following is the most likely cause of this patient's anemia? Hemoglobin is very low.
Mm, between A and C, bone marrow hypoplasia.
Why bone anemia?
Because the risk,
Thrombocytopenia is present, but she's pregnant. Pregnancy can cause.
but the reticulocyte count is, she has anemia, so the reticulocyte count should be high.
Yes, but reticulocyte count is very low.
And then leukocyte count is also low, platelet count is low, everything is
Leukocyte
low.
count is almost normal, isn't it?
Mm,
Isn't it 4,000 to 11,000?
it's like 4,500, I think. Let me check, but I think it's 4,500. Yeah, it's 4,500. It's between folic acid. I'm going with folic acid because she has a MCV
MCV is high, and
is
in
well, not,
pregnancy, you need folic acid.
but does folic acid is it needed for like platelet and reticulocyte? Yeah.
Platelet is almost normal. Pregnancy-induced thrombocytopenia can happen.
Okay, so you think it's folic acid?
Uh, there is like one thing I want to add. Patient,
What?
he has a history of alcoholism. Alcohol,
Oh, okay, 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 okay.
it makes
So
sense now.
so what do you think is vitamin B12?
No, no, no.
Oh,
Folic,
okay. You think it's folic acid? Okay, let me pick one. Yeah, I guess it's folic
you can
acid.
fix your answer.
Okay, ready?
Yes.
Yeah, it's folic acid. Folic acid deficiency is a common cause of megaloblastic anemia in pregnancy because of the increased folic acid requirements, especially when accompanied by malnutrition due to alcohol use disorder. Other causes of megaloblastic anemia in pregnancy include malabsorption and certain medication. In this case, the anemia is caused by impaired DNA synthesis in the RBC progenitor cells due to absence of required cofactors. Symptoms include fatigue, pallor, dizziness, shortness of breath. Lab studies will show a decreased hemoglobin concentration, increased MCV, decreased reticulocyte count, increased homocysteine concentration, normal acid concentration, whatever. Leukocyte and platelet count are generally normal. Peripheral blood smear will show hypersegmented neutrophils. Treatment requires folic acid supplementation and red blood cell transfusion if severe. Bone marrow hypoplasia is a dysfunction of the bone marrow leading to anemia thrombocytopenia. It's typically caused by radiation and chemo, toxic chemicals, medications, autoimmune disorders, and infections. These patient leukocyte and platelet counts are normal, I guess, making bone marrow hypoplasia unlikely. Okay.
Okay.
Okay, we are done. We can take a break and then you want to start the